Hello, I'm Dr. Ruwende and welcome to commonly asked questions about infertility, which we now call subfertility because of the many options which are now available that can make someone to conceive. Today, our answers, we're going to be getting them for a specialist in that arena who is an obstetrician and gynecologist with special interest in fertility and reproductive health, Dr. Madziyire. Dr. Madziyire, welcome.
Thank you very much, Dr. Wende.
You shall allow me to quickly jump into the first question.
Yes, definitely.
The first question says, I am a 35-year-old with no child. My periods are regular. My cycle is for 5 days, which is a heavy flow. However, I have low abdominal or tummy swelling. A scan which was done 2 months ago reported bulky multifibroid uterus. The uterus is in excess of 16 centimeters long, and the largest fibroid is 12 centimeters in the fundus. What are the possibilities of pregnancy in this woman?
Okay, thank you very much, Dr. Wendt, and thanks for the person who's presented that history. She's 35 years of age, and I think she's tried for a couple of years to conceive. I would want to know how many years and whether she's being regularly intimate. The fact that she's got fibroids, there are two possibilities. Either she's got a cause of infertility, which has been there for a long time, and therefore she has then developed fibroids. Because fibroids, we call them stones of a disappointed womb. They tend to grow in the uterus, which have not had a baby for a long time. So women who have not conceived for a very long time have got a higher likelihood of developing fibroids. They are also common in black women. So she could be having fibroids because she's not conceived, she's got another cause of infertility, or she's failing to conceive because she's got fibroids. Because fibroids can disturb the place where the baby is supposed to lie or to implant and grow, or even disturb the tubes so that the fertilized egg and sperms are not able to meet at the appropriate place.
So you talked about the risk factors or people who are at a higher risk of developing fibroids than others. The black people, people who have been for a long time having without a child.
Yes.
Are there any other people who are at higher risk of developing fibroids than?
No, not necessarily. Remember, when people started understanding the character of fibroids, they were picking them in women who never had children. In fact, initially, somebody called them disease of the nuns, because they were picking them in nuns. So, a uterus which is not yet have a baby favors growth of fibroids. Or if somebody has a baby and they spend many years without having another child, in other words, pregnancy or the hormones of pregnancy tend to suppress growth of fibroids. So, and we know they are common in the Negroid race, much more common in the Negroid race. Yes.
The other question says, is it possible for a person who has been operated twice for fibroids to encounter IVF?
Yes, very much so. In fact, we do lots of operations in preparation for IVF. We want to take some fibroid for IVF. We want to make sure the uterus is clean. The surface where the baby is supposed to implant or grow is clean so that the attachment can be proper. So yes, we want to make sure they are free of any fibroids, especially ones which are right innermost aspect of the uterus.
The next question says, I am a 43-year-old with no children. I consulted a doctor and a scan was done. Then the results came out saying I have fibroids which can't be removed unless they have to remove the womb itself. Any possibilities of pregnancy?
Yes, I can understand what the doctors are saying. It can be very difficult to remove very big fibroids. We would obviously want to know the size of the fibroids. But sometimes fibroids, once they are the size of a pregnancy, which is 7 months, or 7 months duration, they become very difficult. They can be removed, but it's a big risk to woman. She can bleed a lot. So I know we would still try a lot, but sometimes the fibroids are so multiple, there are so many of them, so by the time we finish, the shape of the uterus, the geometry of the uterus is so disturbed, such that it is difficult to try and now put a baby inside. Because when you are doing assisted reproduction IVF, we have to transfer the fertilized egg into the uterus. But if the site is completely distorted, that pregnancy won't take. So for this woman, it might be that, like the doctor has advised, that it now almost looks impossible. In which case, one option will be surrogacy, having somebody carry the baby for her.
Thank you very much for that answer, Doc. The next question says, Doctor, what causes the pelvis or the lower abdomen to swell and at the same time feeling bloated? Are these signs of fibroids? Because I've been trying to conceive for 4 years. Now I'm 23.
We do have a condition called premenstrual syndrome, which some women will feel bloated around the time of their period, and they actually get a distension. These are all hormonal effects. The hormones that can control all the size of the abdomen and the pelvic organs. So it's just an effect of the hormones. But premenstrual syndrome as such really does not predict failure to conceive. It happens in many women of natural fertility. Yeah.
And then the next question says, I discovered that I have a bulky gravido uterus after a scan. So I think this was a report from a scan that she has a bulky gravido uterus. What does this really mean? I'm trying to conceive for the second time, but it's fruitless. I was successfully operated and one tube has been removed due to an ectopic pregnancy. I'm 34 years now. I've been trying for past 8 years. I have no children. How can I get help?
Okay, so I would suggest she's saying she's got a bulky non-gravid, because gravid just means pregnancy.
Okay.
So I want to say a gravid, you would assume there's a pregnancy inside. So it's a bulky non-gravid uterus. She's 34 years and she's been trying for 8 years. So once we say bulk, we say the uterus is bigger than usual.
Okay.
We do expect the scan to describe further whether it's big, whether there are fibroids or not. Sometimes there are no fibroids. If there are no fibroids, it's bigger than usual. Because usual uterus is about 8 centimeters in its longest diameter.
Okay.
When it's bulk, usually you're talking uterus at least 12 centimeters and above. Uterus can become bulky because of a condition which we call adenomyosis. Adenomyosis, whereby the inner lining of the uterus, the one which washes off during the menstrual period, it also grows inside the uterine muscle, making it very big and huge. So they tend to have painful periods. I'm not sure whether she mentioned whether she's got painful periods or not, or whether the periods are heavy.
No, she didn't mention about that.
Yeah, those are some of the accompanying symptoms which those women experience. So, but coming to here, at 34 years.
Yes, she's 34 years, trying for past 8 years with no children. Yes, I think essentially the only thing that, or she also mentioned about an ectopic pregnancy on which ended up being removed one of the tubes. Yeah.
So I think she would then need to have a tube of patented test to make sure the remaining tube is still functional.
Okay.
There's a bigger likelihood that the other tube is blocked. Yeah, I think she's got tubal disease, because once one tube, ectopic pregnancy usually occurs with this tubal damage, it tends to affect both tubes. So I assume she probably is the other tube blocked there. So in which case now she needs a vitro fertilization to just bypass that tube. Yeah.
That tube. Yeah. And the next question says, is it possible for a person to donate a womb to someone who is failing to bear children because of fibroids, incompetent cervix, or polycysts?
Well, not donating it in the sense of giving it to somebody else. Uterine transplant is being done, but on an experimental scale. And they've had more, even in artificial uteruses, they've come up, but in animals. But in human beings, it's really something which is a possibility, which might become like what has happened in heart transplant and liver transplant. There's a possibility that will soon be having uterine transplants. But the way it is happening in terms of childbearing is what we call surrogacy, where you remain with your womb, but you can carry the pregnancy for someone else. Yeah, so that's the only way. That's an indirect form of donating a womb, but you still carry the pregnancy. So for the woman who cannot carry a pregnancy, either because she doesn't have a uterus at all, or the uterus is very distorted, like that woman who said she's got lots of fibroids, we can take the eggs, combine with the husband sperms, and once they are fertilized, then we transfer that fertilized egg into that woman with the uterus, who is offered the service to carry the pregnancy for her, and then she carries the pregnancy.
Once she delivers, she gives the baby.
Yes, immediately after delivery, she gives back the baby to.
That's interesting, really. And the next question says, what are the causes of fibroids? Are some women more at risk? I think that's one.
Yes, we've covered it. Yes.
And what are the symptoms? Are there any symptoms of fibroids?
Yes, by and large, fibroids are usually asymptomatic. In fact, the fibroids are so common, they're just like pimples on our face.
Okay.
So if we're to go into the street and stop every woman who's passing and scan them, we're likely going to find fibroids in almost 40 out of 100 of them, meaning that's how common they are. But the ones which present with symptoms are less than 20%. So we only worry about fibroids if they are now coming with symptoms, which we call symptomatic fibroids. And the common symptom of fibroids is prolonged menstrual periods. This means most women will bleed usually up to 7 days. They are bleeding with a duration between 21 and 35 days. So when somebody starts having very prolonged periods, one of the common causes are fibroids. They tend to be heavier. Now we're changing many pads and producing clots. That's likely to be fibroids. Rarely do they cause bleeding in between a cycle. These are usually fibroids which are now growing in the inner aspect of the uterus, or sometimes they are going through the cervix, which we call prolapse fibroids. Yeah.
And can they be prevented?
Fibroids cannot be prevented, though we know by people who have children early and have many children, tend to be lesser risk. So if you want to call that a prevention, maybe.
Natural one.
Yeah.
So it means that people who get who have their children earlier. By earlier, you mean roughly what age?
Okay, no starter definitely, but we know people are going to have their children usually below the age of 25.
Okay.
We have less chance because we tend to have women usually 30 years and above presenting with fibroids. Yeah.
You do not have any history of having children before.
Yeah.
She says, I have 2 ectopic pregnancies, which left my left ovary completely removed. The right side, the fallopian tube, also was removed, but the ovules were left. On top of that, I have ovarian cysts on the pocket and 3 millimeters of 3 uterine fibroids. How best can I be assisted? That is, if it is still possible for me to successfully go for artificial insemination. Okay,
she needs in vitro fertilization because the tubes are removed.
Both of them.
So they really need just. But what's important to determine is whether the remaining ovary is enough eggs, what we call ovarian reserve.
Okay.
That we can determine by measuring hormone which is produced by the eggs, or we can even do a scan to see whether we are seeing enough eggs. So we usually do both tests. If she has got enough ovarian reserve, it means she can still do in vitro fertilization using her own eggs. If it doesn't have enough, she has to rely on donor eggs, meaning getting somebody who can donate eggs for her. Yeah.
And then she goes on to say, how do I do with severe dysmenorrhea? Is there any medication that can ease the pain?
Yes, severe dysmenorrhea, common cause of endometriosis, what I described as the inner line of the uterus growing elsewhere other than the inside of the womb.
Sorry, boss, maybe just to cut it there. By dysmenorrhea, you may want to...
Oh, dysmenorrhea, this is period pain.
Okay. So,
period pain sometimes usually begins when the bleed starts, or it can begin before the period, which we call secondary dysmenorrhea. The one which is starting with the period we call it primary dysmenorrhea. So primary dysmenorrhea is common in women in their early reproductive ages, meaning in very young age in the adolescent group, before their hormones have really self-regulated. But later on, if with conditions, diseases like infections or endometriosis, you can start having secondary dysmenorrhea, where this pain is starting even before the period. So severe dysmenorrhea, we need to check whether she doesn't have endometriosis, which is quite a common cause of it. What's the age again?
The age is she didn't put her age.
She didn't put her age.
Yeah, she didn't put her age.
Yeah. So early reproductive age, it could just be hormonal imbalance, but later on it's likely to be
endometriosis. And she needs to visit the hospital for that.
Yeah.
So essentially it means also that people who are having this severe dysmenorrhea, they may need to be checked for
they need to be checked, and I think she asked how it can be controlled.
Yes.
It's usually hormonal regulation. The most basic hormonal regulation is just combined pill.
Okay.
It suppresses ovarian function. We are limiting the estrogen, the hormone which actually causes growth of that tissue, which is causing dysmenorrhea. So the combined pill is the most basic pill. Though there are other treatments which can be given, but that's what we usually give, usually 2 to 3 months to control that period pain. In addition to the painkillers.
Painkillers as well. these painkillers, are they just any or?
The common ones is what we call the non-steroidal anti-inflammatory drugs, of which the easiest one to get is usually drugs like Constant, diclofenac, infertility.
And the next one says, what are the chances of IVF working, that is in vitro fertilization, that fisher insemination that I talked about? What are the chances of IVF working when the male partner has been diagnosed of subfertility? She says in brackets, low sperm count and low motility.
Okay, so it depends on the sperm count. For very low sperm counts, then we are taking for IVF. Usually the laboratory person, the embryologist, will select the best sperms, and that best sperm is injected into the egg. We call it intracytoplasmic sperm injection. So they just look for the very or the best sperm, and which is injected directly into the egg. So the chances will remain fairly good if they're just as good as somebody with lots of sperms, if you are doing in vitro fertilization. But if you are doing insemination, you still need a good volume of sperms. Because for instance, really we need to you concentrate the sperms and then inject it into the woman when she's fertile or when she's producing an egg. So you still need a good volume of sperms. They can be low, but they still need to be above a certain threshold. So you need to know the absolute number. But I think she said very low.
Yes, she says she just said low sperm count and low motility.
Low sperm, okay. Yeah, that can be neither you nor there. But I think she would really need to look at the numbers. If they are very low, it means in vitro fertilization.
And then the next one says we are having difficulties in having a baby. I have a low sperm count from the test we did. We have a 10-year-old daughter. When we are having sex, I feel like sperms are not coming out. It's been 6 years of trying. After days, I produce just a bit of sperms. I think they mean the semen, what they can see. Yes.
Yeah. So for men, when you look at cause of male infertility, where we can have what we call impotency or what we call sperm dysfunction. So there's impotency, there's ejaculatory problems, and then there's sperm dysfunction. So what it's describing likely could be ejaculatory problems. There's a condition whereby instead of sperms being pushed outside into the female genital tract, they can actually flow backwards. We call it retrograde ejaculation. It can just happen in some men naturally, or some men it happens after having some surgery, especially around the prostate. So it means the sperms are going to the blood instead of coming out. But this can be tested. We can now test their urine after sex and check whether there are sperms in the urine. So this could sound like a retrograde ejaculation, but it needs to be verified.
And is it treatable?
Yes, it is. Yes, there are drugs, and then even we can actually check the sperms in the blood and do insemination with them.
From the bladder?
From the bladder, yes.
He says, I have a relative married for 10 years, no child. Sperm count ascertained by the doctor was at 12%. And the woman is 32 and is fine. The man is 39 and lacks sexual drive. They have sex even once a month or not at all. Any solution to get pregnant?
I think we need to really evaluate the male partner in this regard. This says 12%.
Yes.
I assume once you say 12 million per male. Sperm morphology we use percentage, but the rest of the counts, quantity we are using million, concentration million per male, number of sperm cells per milliliter. So I'm not sure whether that figure is correct. 12% in terms of normal forms will be actually normal percentage. But because the man has got low sperm count, he needs to be assessed. We need to assess his hormonal status. Having sex once a month is grossly inadequate. So there are actually issues which needs to be assessed. Because for conception, for chance of conception to be good, people can only afford to have sex. I think a minimum of 3 days a week.
Okay.
Yeah, that's the minimum, because when the egg comes, it only stays in the woman genital tract for 48 hours. So that's grossly inadequate. And I think with low sex drive, we need to measure hormones, measure the testosterone, and see whether there's actually a bigger problem than this.
The next one says, I am a 30-year-old male who have been trying for a baby for past 6 months with no luck. I went to a men's clinic for a test last year, and then they said there was too much acidity and very small quantities of sperm, close to none. So I was scheduled to return but didn't due to COVID measures. After that, we used protection at home, but just to see what kind of substances would appear. To my surprise, there was nothing that turned out this time. It was dry. I think he's talking about inside the condom. I then noticed that sometimes after sexual intercourse in my urine, there will be slimy substance that I pass out with the urine. But during ejaculation, I feel that there is something coming out. What could be the problem? We haven't concentrated much on my wife too, since she has 2 kids before me. I think it's something that you have.
Yeah, I think likely we have already touched on this. He is likely not to be producing any sperm, so either it's retrograde ejaculation. So again, we need to realize this. Some people have retrograde ejaculation, then some people have actually blockage in the tract where the sperms are going to pass through. So again, you have blockage, so he needs to be evaluated and see whether anything is really coming out or not.
But he's saying that after sexual intercourse, right, the urine, there will be slimy substances. Slippery or slim, I don't know how to.
So this could be sperm, so it could be retrograde.
Which you said is treatable. I am a 33-year-old. I've struggled with left testicular pain with no one would really help. I then went for fertility tests, sperm count, and the sperm count, and realized that I was infertile. My volumes were so low. I had an operation for transurethral opening of the ejaculatory ducts, and another one because they suspected it was a small varicocele, and nothing helped. And then I gave up. With the left testicular pain lingering, I was confused. I'm confused daily, and then started seeing blood in my urine and panicked worse. My worry is on the infertility part. Yeah, that's his question.
What is he?
He says he's 33.
33 years old, okay. Yeah, firstly, like the history suggests, varicose was that testicular pain, but it seems it was a small one which has been repaired, and it seems also the urethral blockage, which they've tried to treat. So I think he's got a problem in the passage of sperms. The best thing would be to do what we call testicular retrieval of sperms, or that's a didymis retrieval of sperms, where you try and take the sperms before the site of obstruction. There are ways of actually aspirating them, and then you do insemination. Insemination just inject them into the female partner when she's fertile.
So hereby, are you injecting into the ovary? Where are you injecting this one?
Okay, into the vagina, to the cervix.
Okay. And then the next question says, we have been struggling with having a baby. I fell pregnant once in 2015, and it was an ectopic pregnancy. Then he had an IVF in 2017. It failed with no embryo. I have 1 tube, and there is also male factor in our relationship. My partner continues to drink alcohol excessively. Could this be a contributing factor? And then nothing is wrong with my remaining tube after the ectopic pregnancy. It was scanned via HSG and also confirmed via laparoscope surgery that it's very healthy and viable. But we can't get pregnant, and I can't seem to take off the feeling that we have problems with the male factor as a result of the male factor. On tests done, the sperm count has been below with morphology concerns. So I think,
so I think slightly the male factor contributing. Of course, sometimes we can have mixed factors, both male and female factors, but from what she is saying, it's likely to be mainly the male factor. But of course, we always need to know how bad it is, because if a reasonable quantity of normal cells can be retrieved, then insemination will be an option. But I think because the doctor already offered IVF, it means that maybe this were grossly reduced, and which means their best option is to continue trying IVF. So what you know for IVF, people need to remember that for women less than 35, the chance of success at the best are just 50% per trial. So there's still a odds that 50% of women who still fail to conceive, even when everything else is fair or is okay.
So they need to try again.
They need to try again, but we know it's very expensive, but it's important to try.
We have been married for past 2 years and trying having a baby, and all has been in vain. We were once given subfertility pills and examined by the doctor, but by now there is no change. We are both 30. We do not have any children outside our marriage. My wife does have regular periods. We have had tests done in South Africa by one of the doctors there. She was diagnosed with PID. And then we were given both injections and tablets. Later she spent about 7 days being put on a machine that one cable goes through her genitals and the other through her mouth. The doctor then advised that all was well and we could have kids, but they haven't had any for the past 2 years.
So yes, she described that they've gone for 2 years. Majority of couples, normal couples, 84% will have conceived by the end of the first year, and then 92% by the end of the second year. So the moment you go beyond 2 years, there's likely to be quite a significant problem happening. In their case, they seem to say they've not identified the cause. We do have a criteria which we call an explained infertility, but really see, you need to rule out many things, make sure they have normal status, they are not overweight, everything is functional, the sperms are okay, which I assume is being done already. So it means they've got an explained infertility. The treatment for unexplained infertility becomes IVF when everything was being tried. So I think they have to go for IVF.
For IVF. She says, does yeast infection cause infertility?
No, it doesn't.
It doesn't. Thank you for that. And the next person is, I don't know what to do. I got married late. I had my first child at 37, but the problem is I can't get pregnant for my second child. What should I use? I'm turning 41 in December. I had my first child in 2018, that's when she was 37. And started trying in May 2019. I have regular periods.
Okay. So fertility drastically goes down after the age of 37. The graph really plummets down. So because the eggs are getting reduced in amount. So women are born with all their eggs, and during their reproductive years they are getting diminished slowly. So after the age of 37 they are really low. So it becomes very difficult for pregnant after the age of 37. More so after the age of 40, which is what is affecting it. We call it reduced ovarian reserve. So first thing to try, since she's having regular periods, we try to do some ovulation induction, giving drugs which can stimulate the growth of the eggs. She needs stronger and stronger drugs. There are simple drugs people usually get from another doctor, but sometimes in that field they even need stronger hormones. These are equal to hormones which are produced in the brain, but we can give them as injections to really dry those ovaries to try and squeeze all the few eggs remaining. Unfortunately, after the age of 40, even with IVF, success rate is dismally low.
Because of in law.
It's at the most 20%. So, but it's worth an attempt. Let's say try with ovulation induction. If that fails, and then you can then have to try IVF.
I'm not trying to have a baby yet, but I'm 37 years. I've never been pregnant before or used any contraception except condoms. My question is, since I'm not in my prime, what are my chances of conceiving naturally? She says, realistically.
They are now getting very low. Like I said, from the age of 37, it's really plummets down. But the biggest cause of infertility is advanced maternal age, advanced women age. So conceiving is very easy for women up below the age of 30, and then it starts getting slow, plateauing up to about 35, 37 it really drops down. So the chances are now getting greatly diminished, and the more you reach 40, it becomes even a bigger struggle to conceive. So for somebody wishing to have a baby, then the advice will be this will be time to really try and make that decision and conceive. Other than the reduced chance of conceiving, then even problems, the body can't really carry pregnancy very well, especially after the age of 35, start having more complications with pregnancies. So the advice will be, if everything is okay and she's in a relationship, she might as well try now.
And the next question says, I have a question. I'm 37 now and I still need another child. I'm doubting because of low blood flow I'm having these days, but still my days are very normal. Is this safe or I'm reaching my menopause? I got married at 25. I had first born at 30. I'm now trying for a second born.
If you want to try this, better try now, because that's really the turning point where reproduction really gets greatly diminished. So I think it's best time to try. And the issue with advanced maternal age, again, they are now increased risk of also baby abnormalities. Chance of having abnormal babies becomes higher with advanced age. Most of all in women are above the age of 35 and when men are 50 and above.
So when men are 50 and above and women are above 37?
We usually 35 actually.
It's at 35?
Okay. So in addition to reduced fertility as well, these are disadvantages. So the sooner you try, in fact, when you're looking at chance of having babies with abnormalities like Down syndrome, when women are above the age of 40, the chance of having a Down syndrome is almost 1 in 400. Below the age of 30 is about 1 in 1,000. So that the chance of having abnormalities is increasingly going up.
I had my first baby at 34 in 2013 through a cesarean section. He's never used any contraception. Then used IUD from that time until 2017. That is 4 years, and removed it. Till now, since 2017 I think, till now I've been wanting to have another, but it's not happening with the same partner. Not sure why. I'm now 42 and my husband is 47. He does not drink. I have regular periods. He had other kids before we got married in 2012. I only have one with him who is 8 years now. The only prevention I ever used was an IUD. Before the baby, I was never sexually involved.
Like we've been mentioning, 42 is really advanced maternal age. It's very difficult for pregnant at the age of 42. She can get what's called an ovarian test, but invariably it's always very low. So for many women, usually above the age of 40, they're hardly using anything and they don't conceive. She gets so far pregnant, but the chances are very
slim. The next one says, how are you, doctor? My wife is 30 years old, is failing to get pregnant. She was using an injection, a Depo, since 2017 as a way of preventing pregnancy, which we stopped 6 months ago. After she stopped using it, she didn't go for periods for some time. She started having periods end of January, that's about 3 months ago, and they are regular. We have 2 sons, the older one is 5 and the other one is 3.
So when using Depo, you can have delayed return of fertility. It's nothing abnormal. Depo is concentrated in the muscle and when you're suppressing the way the body functions. So its effects usually wear off after between 5 and 6 months. It's given every 3 months, but they give a safety period so that people don't have unwanted pregnancies. But it's going to function for almost 5 months. Most women will be able to conceive after 6 months. There are some with delayed resumption of fertility, which can go up to a year. But they must not worry. It does not cause permanent infertility. Eventually, the system will keep back into normal. So usually the longest is up to a year.
So they still have 6 months more to keep trying. They are still okay, no problems. And then, hi doctor, my question is on the effect of morning after pills. Do they have any effects regarding fertility? Also, how many should one take per week or per month?
Thank you very much. They don't have any long-term effects on fertility. Just like contraception, I know people only think contraception affects fertility. So they are just disturbing ovulation and sometimes implantation. So their effects just work during that cycle.
During that time, they doesn't go long term.
They don't, And then she asked how many one should take. There are standard doses, which depending which type you are taking. There's protein, which is levonorgestrel, which is what I taking as 2 tablets once. Previously, we used to take them as 1 tablet, repeat after 12 hours. Some people can use a combined pill, which is again taken twice again. But we expect people to just use them at that moment where they've had unexpected sexual intercourse. So they expect to be a routine method. It's better if you want to use them routinely, you might as well just take a pill which you are taking regularly. Because sometimes they don't work.
The next one says, I'm a 35-year-old mother of 3. I had tubal ligation at 29, but now I feel like I want another child. Is it possible? Of the 3, I have two are cesarean sections. So maybe Mr. Beck explain what's the tubal ligation which he had at 29.
So hair tubes have been tied as a way of blocking tubes. So the best way for hair is to do in vitro fertilization. So in vitro we are bypassing the tubes. We are just taking the eggs from the ovary and combining the sperm and then transferring back in the uterus. So we don't need the eggs, because the egg is supposed to travel along the tube. But however, there's a possibility of tube or vessel, but it's a very low success rate, just up to 20%. And depending on the tubes were cut, usually just loop and remove a portion of the tube. But if the doctor decided to remove a whole big portion, including the ends of the tube, then it becomes almost impossible.
Almost impossible.
Yeah.
How fertile is a woman after salpingectomy? Salpingectomy rather.
If it's on both sides, we expect it to not to be fertile, both like tubal ligation, we remove the
Salpingectomy, what does it mean?
Okay, the tubes have got finger-like processes. These are like finger-like, they've got like hands with fingers. Those are the ones which receive the eggs. So cutting
From
off
the ovary.
So cutting off the tube is what we call salpingectomy. So salpingectomy usually means removing a section of the tube, including these finger-like processes. So it means there's nothing to receive the egg. So if both are cut, we expect the chances of fertility to be almost zero. If one is cut, the chance remain fairly good.
But can she go for IVF?
Yes, definitely. That's the option.
Oh, that's the only option. I'm 35 years with no children. I've been trying since past 7 years. I have irregular menses. I started skipping 3 months. Then after those 3 months, the period will last for 9 to 15 days. Now I can even skip the whole year. And when period comes, I only see spots. I had a scan in 2020, which reported both ovaries were enlarged with follicles suggestive of polycystic ovaries.
Yeah, that's typical of polycystic ovarian syndrome. This is a condition where the ovaries are not producing eggs, they don't produce them regularly. So in the women, they tend to have excess male hormones usually, and sometimes they can be overweight, and we also see like ovaries with multiple cysts are just little balloons which contain the eggs. But the eggs don't mature now in polycystic ovarian syndrome. That's why they are remaining infertile. So with polycystic ovarian syndrome, if she's overweight, then she would need to lose weight. It does help a lot. And then ovulation induction usually works very well for polycystic ovarian syndrome. So I'm not sure what she's tried, but most women with polycystic ovarian syndrome will eventually conceive.
And so this 1 year of not having periods with induction, it can...
It's typical of polycystic ovarian syndrome. They tend to have infrequent and absent periods.
In fact, maybe you can tell us about the symptoms of the...
The symptoms of polycystic ovarian syndrome include what we call anovulation, which is meaning failure to ovulate. And when somebody is not ovulating, they have irregular periods, which can be very erratic. They can go for usually up to 3 months without seeing a periods. Eventually, they can start going longer and longer periods, like she's going even up to a year. So that's the symptoms of anovulation. We can also prove it by also testing for the hormones. And then they can have what we call hyperandrogenism. Hyperandrogenism means excess male hormones. So they can have excess body hair, or we can measure the male hormones that you see they are elevated. Then they can also get what we call polycystic ovaries, like what she's describing.
Can be seen on the scan.
Yes, on the scan, So she's got 2 of the markers, which is what is required for a diagnosis. So this is definitely a case of polycystic ovarian syndrome. And the most important aspect is really to try and promote ovulation. And promoting ovulation, if she's overweight, she loses weight. If she is overweight, she can also give what we call insulin sensitizers, drugs for diabetes like metformin. They help a lot in that regard. And then ovulation induction, starting with simple agents like clomiphene, and eventually going to what we call gonadotrophin, the injections now, which really drive the ovaries to produce eggs. If that fails, then eventually it's IVF.
But she still has some possibilities like what
you
explained. I am 29, got married to my partner at 23 in 2019, but up to now she hasn't conceived, so it's the wife who's 23. At one time she had the last period in November 2019 and skipped 6 months, then went on a period again early in June 2020. At this moment I thought she was pregnant, but to my surprise she wasn't. Later on, her last period was in August 2020 and skipped another month and went to period late December. She just went for 2 months. From January to present date, she hasn't got her periods. What can we do? And now it's physiologically affecting me because I need a baby of my own. So I think this one also she has been going for 6 monthly period without going for period, and then goes for 2 months.
Okay. So she has got typical features of an ovulation, which would be typical of polycystic ovarian syndrome, but would need more history. But I just wanted to correct this statement because while there are features pointing in the wife, he says up to now she hasn't, but he must actually say up to now we haven't conceived, because sometimes we have mixed factors. There could also be more factors, which then makes it the problem a bit more pronounced if we have mixed factors. So for initial assessment, you want to explore both partners, whether there's contribution from both partners. Yes, there's both features of polycystic ovarian syndrome. So with ovulation induction, that she should be able to conceive.
And you'd gone on to say period was normal, but it started after getting married, that is in 2019, that she had issue of bleeding after period. The issue of bleeding was there even before getting married. She had issue of bleeding. So I was married in 2013, but up to now we don't have a baby. My wife, 35, does not go for her menses. She last went in 2011. She started going for her menses in about 20 years, but they were irregular.
So she could be having what we call premature ovarian insufficiency. Some call it primary ovarian insufficiency. It used to be called ovarian failure. But so she hasn't gone for periods for a very long period. She had started late. So there are conditions, some which are inborn, where there are chromosomal problems where the eggs don't just they are not produced. We have what I call Turner syndrome. With this variant, some women never go for their period. Some go briefly and then they stop for good. So there are many variations. So we would need to explore the wife for the possibility of primary ovarian insufficiency. And if that's the case, then she would then need donor eggs for her to have
a baby. I'm having irregular menses. It's almost a year without encountering. I've been visiting the clinic, but no test has been done so far to find out the problem. But on my last appointment with the doctor suspected a hormonal imbalance and advised me to take family planning pills for a month. I did that and experienced my periods. That was after a year. But the problem came when I skipped taking the tablets. I'm now continuously bleeding, and it's almost 2 months experiencing this. I really need help. I'm 29, married at 20, no child yet.
Okay. Yes, with looking at her history, first she has had this abnormal flow pattern, irregular periods, and then she gets treated with contraception, and then she starts bleeding erratically. So we tend to have that pattern as when people stop the pills, they tend to have a period where they are bleeding erratically. But eventually she goes back to her usual pattern. So what you need to establish is why is she having that irregular pattern, which usually indicates that she's not ovulating. There are many other conditions other than the usual polycystic ovarian syndrome which you've mentioned. You can have other hormonal problems which can cause it. You can have people with conditions like thyroid diseases. They can affect the way, or even certain hormones in the brain which called prolactin. They can disturb the way the cycles are functioning. So sometimes she needs a thorough evaluation and really pick the problem of where this hormonal problem is starting from.
So she needs more tests.
More tests, yes.
Can clomiphene be used by persons with PCOS, that is polycystic ovarian syndrome, when trying to conceive?
Yes, that's actually the first line drug. It's after trying to lose weight or even trying the anti-diabetic drugs, clomiphene is the next agent to use ovulation. So it's very effective. Most people will be able to ovulate on it. But it's only useful for people who are not ovulating. If you give someone who's already ovulating, not much benefit from it.
Then the next person says, my doctor discovered that I have cysts which are resulting in the existence of PCOS, polycystic ovarian syndrome. 4 months back I experienced irregular periods, but last month I skipped my period and I was very happy with high hopes that I finally conceived. Today I did my pregnancy test and the results were negative. I'm so hurt and devastated. What should I do?
Yes, okay, there's an indication of polycystic ovarian syndrome. But what I need to also warn people is that polycystic ovaries by the source doesn't necessarily mean polycystic ovarian syndrome. We need other features as well. But if there is irregular periods already supportive of that, or if there are issues of excess male hormones. That so we don't know whether her period has become erratic because she's got PCOS, or sometimes even the pressure for pregnancy can raise stress hormones like prolactin and start postponing periods as well. So sometimes we create a vicious cycle where the period.
So the stress of having a baby can cause you to not to ovulate.
Yes.
Okay.
Yeah, sometimes it's lots of pressure. Like what you say, somebody's anticipating to conceive, and then the period comes back again. It's a devastating feeling, and it actually now starts acting on the body.
So she can keep trying.
Yes, she can. Yeah. She will need more counseling and keep trying. Yeah.
Can I use family planning pills to regulate hormones when my menstrual cycle is not constant? And what may be the negative effect of continued use of these tablets when you never given birth?
They don't have a negative effect in terms of making you fail to conceive, but for certain women, we don't want them to use, like women with hypertension or women who are overweight, women who smoke, because they tend to increase the chance that blood thickens, so they can develop what we call thrombotic disease, where they form clots which can block elsewhere in the heart or in the brain, causing strokes or heart attacks. These are really some of those peripheral side effects, but in terms of regulating your flow, they won't affect by making you fail to conceive.
So the best is for a doctor to assess you first.
Yes, definitely.
Yeah.
And looking for contraindications.
Not to prescribe yourself the what do you call them,
the combined pills.
The combined pills.
Yeah.
What causes irregular periods?
Okay, it's basically hormones. Remember, menstruation is directed by the hormones. The hormones start from the brain. The hormones in the brain which drives the ovaries to function. What's actually happening? The body is preparing for a pregnancy in each cycle. So firstly, the hormones make the lining of the uterus thick. It's like putting manure in your food so that some seeds can germinate. So the uterine lining is thickening. If no seed implants, the uterine lining is washed off. That becomes a period. It becomes seeds again. Then the whole process kicks again. So these hormones are regulating, but sometimes they are disturbed in their function. Once they are disturbed in the function, you then start getting disturbed bleeding, erratic bleeding. So that's why we tend to use hormones to try and control the abnormal bleeding pattern.
And when should one visit the hospital and see doctor with irregular periods?
I think the sooner the better. We know for people who just started their periods, it's common for young girls to go for a period of 2 years with irregular periods. So early in reproductive life is not advisable, but once in the active reproductive life, when somebody is going beyond 2 years of periods, we expect them to become irregular. If they are being irregular and if they are being painful, somebody should be seen. Then later in reproductive life, after the age of 45, they can become irregular again because the ovaries are shutting off, they are reaching menopause.
The next question says, "Hi doc, I've been trying to have a baby for the past 11 months. My girlfriend once had an abortion and claims the medication she used was safe. I have kids from my previous relationship and did a sperm analysis which came out satisfactory. There was no problem. We have sex almost every day, barring when she's on period. The abortion was 2 years ago. The periods are very normal. She's willing to have a baby as far as I know." He had asked her whether the lady is willing to have a baby. And so he says that she's willing.
Alright, so likely they are both normal. Like I said, the 84% of normal couples only conceive in the first year, and then 92% by the end of the second year. So there's a hypothesis that they will still be normal. However, she can have a tube or patency test to test whether the tubes are normal. There's a simple test which we call stereosalpingogram, where dye is pushed through the opening of the womb, and we see whether the tubes are open or not. But we should want people to go for at least a year without getting investigated, because we know that most people are like to just conceive without us intervening.
So before 1 year of failing to conceive, people shouldn't get worried much. There's no need to go and see a doctor.
The only time we say you should worry is when you're 35 and above.
35 and above.
Because you don't have much time.
Much time.
Yeah.
Okay, we are rushing with that. And then the next question says, "Doc, we are failing to conceive since September 2019. My wife is 38, same as me. I have a 13-year-old daughter from a previous marriage and have had another. However, my wife seems to struggle to conceive. Please help. Her periods are regular, though there was a time in September when she skipped for 2 months. We thought she was pregnant. She goes normal for her periods. They've been trying since 2019.
Yeah, so now it's another situation where the wife now has got to reduce ovarian reserve. That can be tested, but this is likely now contributing. What we do want to know is whether she tried when she was younger, if there was already a problem when she was younger. But if she's tried after the age of 35, it's likely to reduce ovarian reserve. So in fact, anybody having problems in conceiving after the age of 35, we test for ovarian reserve and say how functional are the eggs. And most often that's the commonest cause of delayed fertility or even absent fertility.
Which you said you can also try to do the induction.
Yes, we can try to stimulate those eggs.
Stimulate them, okay. I am a male aged 28. I fell in 2003 and my testicles retracted. That has affected my ability to produce seed for reproduction. Can we say it's possible to have a child? Erection and sex drive are all normal. I do produce semen during ejaculation. I've been having sex for 4 years now, though it's not regular.
Yeah, so it does mean that he has been affected by falling. So I would assume maybe they did sperm analysis and they saw that the sperms are reduced.
Because the person had his testicles retracted, I think since 2003, maybe up to now. And I've affected, it is affected, so maybe he has been tested.
So after accidents, one common problem is what we call urethral strictures, which cause narrowing in the passage or in the route which the sperms use.
Okay.
So that can be corrected by urologists. These are males dealing with the male reproductive system. But it needs investigation. That can be easily proved. They usually can look through the urethra and see whether there's strictures or not. So it needs that check.
Hi doctor, if I have a problem conceiving my womb, I have a problem concerning my womb which is said to be small. Will I be able to conceive again because I've been trying for more than 25 years? My baby died after 7 days of birth.
Okay, so she's been told she's got a small womb, and she managed to have a baby before. Small womb, we call it in an infantile uterus or hypoplastic uterus. It just means there's not enough hormonal stimulation, not enough estrogen to make it normal size. A small womb is usually 5 centimeters or less. The normal one is about 8 centimeters. So
the longest.
So the estrogen stimulation is low, but women who are menopause also tend to develop the womb becomes small. So commonly women reach menopause between the age of 45 and 55. So when they stop their menses, the womb also becomes very small. There are some women who get what we call early menopause, which is between the age of 40 and 45. Below 40, we call it premature menopause. So she could fit any of those categories, but we need no more information. Firstly, age as well. Since she conceived 20 years ago, could she be in the menopausal range, in which case the womb naturally becomes small? For somebody of normal reproductive age, it's easy to give hormones and make the womb big, but what's important is whether she has enough ovarian reserve or not. If she doesn't have eggs, then it means she needs somebody to donate eggs for her so that she can conceive.
So the small womb, if they are within their prime time, there are hormones which can be given to increase it in terms of size. Okay. And the next question says, my sister who is 38 had a son in 2006, fell pregnant again in 2010, and had a daughter who passed on after 4 days. The reason for passing was gastrangarapira intubation. She fell pregnant again in 2017, but it is stillbirth at week 39. She has hypertension and also has piles from time to time. Until now, she hasn't been able to fall pregnant. What could be the explanation? She has been having the same husband for 17 years now.
Yeah, it's a very sad story. I'm very sorry about this story because she had conceived and initially the baby, I think the baby was preterm because they had some problem in delivery and they died soon after birth. And they fell pregnant and the baby died in the womb likely due to hypertension, like she mentioned, which are common problems happen after the age of age of 35. So I assume she's already 40 and above if I add the years.
She's 38. She's 30.
Yeah.
38.
She started at 38, isn't it?
No, I'm
now
saying
she's 38.
she's now 38.
Yeah. So again, she's got to reduce ovarian reserve. She can still get ovarian induction, like what I said, try to stimulate the ovaries. But the issue of hypertension in pregnancy, they become a big problem. So this time, if she falls pregnant, then this baby needs to be closely monitored. They need to measure how the baby is growing and whether the placenta is functioning well, and even delivering earlier than waiting for term. Yeah.
Meaning she has to present to the hospital as soon as she gets pregnant.
Definitely.
And it's followed up more frequently.
Yeah.
We are a young couple. We've been trying to have our first child. We married in 2017 and have been trying since. The first pregnancy ended in stillbirth days before term or delivery date. Then we stopped trying for 2 years. Last year we tried again. She had a miscarriage after 6 weeks and went to be cleaned. Last week she missed a period and we took a pregnancy test which came out positive. We went for a scan and the scan results only showed a 3 centimeters declining. The radiologist asked us to come back in 4 weeks as she thought we went for scan too early. We need help on what steps to take to ensure that we celebrate our first child. We don't have any gynae yet, please assist.
Okay, yeah, it's not very clear. What we know is she has had 2 poor outcomes so far.
In the early weeks.
Yeah, and what's happening now? She could still be very well pregnant, but they just did a scan too early, so they could still see a baby growing. But now we are saying, how do I avoid the initial problem when she lost a baby? She lost a baby in the womb, isn't it? And then she had a miscarriage for the second one, is it?
Yes, yeah. She had 2 miscarriages.
2 miscarriages.
She had a miscarriage after 6 weeks, and then which was cleaned, and then she also had, and then the first pregnancy ended up in stillbirth days before term. So the first one was days before term, and the second one was at 6 weeks. It was the stillbirth.
Okay.
So what he is asking in terms of how can he prevent this?
So for them, this could be an unrelated event. So this could just have been accidents of nature, which are unlikely to be okay. So while of course this pregnancy needs to be monitored very well, there's a good chance that the events are completely isolated, just happen sporadically. But the important thing is she needs a full assessment to make sure she's not diabetic. She doesn't have another condition which can affect the development of the baby. So I think just close monitoring. She needs to register at a center or with a gynecologist who can do very close monitoring and give all the supplements and necessary support with the pregnancy.
Dr. Madziyire, these are the questions that we had. And do you want to say something before
okay, thank you very much, Dr. Yes, I know there are lots of concerns. People really want to understand how their reproductive system works, and which is very important. So what I want to encourage is that people must come for evaluation as couples. Often the male partners, they tend to stay away and they think they are not part of the problem, but we know very well that there's an equal proportion. So please, men or our brothers, be open up and come with your wives or spouses for evaluation.
And especially now, because there are many options that we can use to make a couple conceive.
Definitely, yes. Yeah.
Thank you very much, Dr. Madziyire, for giving us your time. We really appreciate your busy schedule, but you're giving us your time. And to our listeners, thank you very much for listening to our program.